So just to give you a little background, we've been developing evidence-based resources to encourage the engagement of folks who are affected with hepatitis C care specifically since 2011. And we've been doing that with a national network of people who are affected, but also the providers who are serving them. Some of you are in the room here have been helping us, and thank you. So the resources that we've developed to date have really meant to engage people along the entire hepatitis C care cascade. And the cascade, as we've mapped it out here, is really a public health informed cascade. So it includes everybody in the general population through to the at-risk and or affected before they're tested, right through to the need for treatment, a potential cure, as well as public health follow-up to prevent reinfection and or to catch the kinds of consequences that result from having long-term liver damage. So some of the resources target specifically the particular points along the cascade. So for example, our frequently asked questions booklet, which is here on the, I guess it's the right side of the screen for you, address in particular some of those misconceptions that Jordan Feld referred to today. So that helps to engage people right from the point at which they're being tested or feel they may be at risk, through to keeping them linked and getting them linked to care so that they are not dropping out of care at these various transition points in the care cascade. Other resources we've developed, including the website and some of our online courses, for example, span the entire cascade of care. And while we've developed a lot of the resources based on evidence that we've gathered from people who are affected, so that is, they already have knowledge of hepatitis C and some of the issues around it, it's really informed prevention as well, because it sort of preempts the kinds of knowledge misconceptions that are out there that can prevent people from even getting tested. So what do these resources look like? They're in print, as in the booklet here that you see that you can order from us or through Katie or download online and print off. We have also turned some of them into videos that are accessible online, which really helps access folks who are maybe not quite as comfortable with language, English language issues. And so it's read out. And you can also read it. The text is there as well. We've developed also a website, Hepatitis Education Canada, where we've been able to put all of our materials online for easy access, at least for those who have broadband access. We've also, and the website is actually features a patient and provider portal, because a lot of our resources are really aim to create dialogue between both groups and address some of those knowledge gaps that are present in both groups. And through that, the use of the resources, some of those misconceptions can be addressed. We've also developed, just here on the left side, some other resources that just help build confidence in consumers' ability to self-manage their illness and their disease management strategies, and we find that that helps to mediate some of the stigma that's involved with having hepatitis C. One of the other things that we're doing now is to try to map out some of the factors that are involved with engagement according to a health behavior framework. So we're going through the literature as well as our own research and mapping the personal and interpersonal and system level factors that can impact on engagement. And so we're working on that currently. We've been able to map our resources to where they are having impact on that kind of intention forming around seeking care for hepatitis C. And what this will also help us to do is actually map out the gaps in the framework where there is no research. And then we hope to develop a more quantitative survey that we can use for those affected on an ongoing basis to understand the factors as they are now, and then also as they change over time with the shifting landscape. So just to step back a bit and tell you what we discovered through our 2011 research phase with 55 people who were affected by hepatitis C and about 29 providers that we interviewed across Canada. We found that there were about 6 major factors affecting whether or not people were attending for hepatitis C care, and these factors are present at the individual, provider level, and system level. Some of the factors cross-cut the different levels. So for example, stigma at the individual level, there's a lot of self-stigma involved with the diagnosis of hepatitis C that prevents people from even being tested and disclosing to their support communities that they have the virus. But then also stigma at the level of encounters, in clinical encounters, can actually reinforce that stigma and cause people to drop out of the care cascade. And then a feedback loop can be set up at the system level where media reflections of hepatitis C emphasize the stigma associated with the disease. For example, the portrayals of people with hepatitis C as invariably being injection drug users. Some of the factors are particular to different levels, so the cost versus benefit analysis that goes on at the individual level and the competing priorities are particular to that level, but most of them are cross-cutting and reinforcing and compounding on one another. So what are we doing now? We're in this phase of our project, what we're engaged in doing is focus group testing both those factors that we've discovered in the general population and the resources themselves with the Punjabi-speaking community across Canada. So we've done a number of focus groups already, and what we've learned so far through these focus groups is that, again, we're finding patient, provider, and system level factors are at play. Hepatitis C knowledge is, as expected, is quite low, actually, for all the hepatitis strains. The discrimination and stigma is also present, but in different ways. So the stigma around hepatitis C often involves things like not wanting to be associated with the disease itself, not so much because of drug use, but because of being a person of color. There are insurance issues as well, so most folks are not covered at all and have no access to insurance until 3 months after they've arrived. And even after that, many folks are self-employed and so don't have access to medical benefits that would help them engage with care on a more ongoing basis. And the healthcare system navigation issues, of course, are, as many folks have alluded to already, always at play. We need to, in our future focus groups, sort of elaborate that a bit more, what the particular barriers are, and as a national project, we want to identify the ones that are applicable across the country. And then there are also addiction issues. Alcohol use, folks are telling us, is often a barrier to accessing treatment. People don't want to stop drinking, and so they don't engage for their specialist appointments. There's also cultural issues as well, which are really interesting and we'll need to elaborate on more. But often folks are not disclosing and accessing care because of a culture of sort of fatalism, that it's God's will and that there's not a lot they can do about it. And misconceptions such as the fact that hepatitis C is sometimes thought of as a death sentence compound that, because then there is nothing they can do. And that's also feeds into the fact that for many folks, not burdening their families with their own healthcare issues is a big piece of not disclosing and not seeking care. They don't want their families to be concerned or to have to take responsibility for their care. There are lots of provider relationship issues that that have come up that we'll be exploring further as well. Things like when folks first arrive, they'll often access South Asian docs or docs in the community that are serving them. And they have told us that some of those docs tend to act as gatekeepers a little bit, discouraging testing. So people will go forward and say, you know, I'm very fatigued, but they'll be... Oh,
please go
thanks.
On.
That, you know, they'll present and shouldn't I be tested, and they'll be told, oh, you're just fine, don't worry about it. There's also issues of breaches of confidentiality, so they're afraid that if they access care through their docs that it won't be kept confidential. And there's lots of issues around the stigma towards lesbian, gay, bisexual, transgendered, and the queer community, and people who inject drugs as well. So we're continuing to explore those factors, and we'll hopefully have a report to share with all of you in the next year or two. And we're in the process of finalizing the resources that we've already developed with the community now, and we'll probably identify some new resources for the future. And I'd just like to thank our knowledge translation expert, Terry Buller-Taylor, and the other members of our team, as well as our hardworking advisory and working group members, and our funder, the Public Health Agency of Canada. And if you'd like more information, please contact us. Thank you.
Thank you very much. I have one question for each of you. So, Naveed, interesting data. The higher prevalence of hepatitis C in the South Asian and the Southeast Asian population in areas where there's fewer immigrants. That's what I understood from that slide, right? Is that?
No, so that slide, it's a little bit confusing. Let me get back to that slide and then. So this is a percentage of population which is of South Asian and East Asian origin. So this less than 25% means like only less than 25% of population in that neighborhood is of South Asian and East Asian origin, and other population is of other ethnic or immigrant origin, and that shows like most probably we have higher positivity rate in Canadian population compared to those who are foreign born in the way this data is showing. And that's why I was highlighting the issue of access to testing and how much we are testing our population, and that's why we need to couple it with population level surveys in these populations to get a better sense on what is actual prevalence or burden of disease in these populations, because if these people are not seeking care or if physicians are not offering them testing, then they will be underrepresented in our surveillance data that we have.
So the South Asians that are in the areas where there's less than 25% immigrant populations have a seroprevalence of 6%, whereas in their own communities they have a seroprevalence of 4%.
No, we don't have any identity at individual level, so that's why we use neighborhood ethnic distribution to say that neighborhoods where greater than 75% of population is South Asian, so we expect like that is more South Asian population. So what is prevalence? So that is, it becomes more ecological at the neighborhood level. So hepatitis C testing is more individual level, but the ethnicity data was not included in that. So that's how we went to census data to identify neighborhoods where with distribution of ethnicities, and on that basis we classified it just to get a sense what is happening in our communities, and then plan for next steps in terms of surveillance. So this shows that areas where there's 75% of population is of South Asian origin, percentage positivity for entire population is around 4 point something percent, and areas where South Asian population is less than 25%, percent positivity is around 6%. So areas where we have higher ethnic concentration of South Asian, percent positivity for that entire area is less than 4%, or is less than areas where you have lower percentage of South Asians.
So how much of this may be socioeconomic status, other risk factors in certain neighborhoods that are not immigrant neighborhoods? I mean,
Exactly.
if we're
So
talking
that
about
is
an ecologic-
so that is one of the issues with testing data. So since our testing is mainly based on risk-based testing, and then we have like a huge testing, especially in BC for a baby boomer group. I didn't show some of these slides. So that is like a huge group, and that could be pushing some of these percentages, but that's where we need to look at burden in the population to understand like what are the percentages for this. So coming back to one of the point that came in Jordan's presentation and also to your presentation, so much of my work around hepatitis C has been in Pakistan, and so looking at injection reuse, and that's where I started working on. So injection reuse is very common in areas which are poor neighborhoods, and also in remote rural areas or rural areas. So being lower socioeconomic status and then living in remote rural areas, you're more likely to receive care from non-licensed professional, and then these non-licensed professionals are more likely to reuse injection equipment. Licensed professionals are also reusing injection equipment, but that reuse is less common compared to non-licensed. So most of immigrants who are coming to Canada, they are relatively well off compared to people from remote rural areas or from slums or from poor neighborhoods. So from that perspective, prevalence of hepatitis C among Pakistanis here in Canada could be lower than what it is in Pakistan, but overall prevalence of Hep C in Pakistan is so huge that we do expect like a higher prevalence among that population in Canada compared to the rest of Canadian population.
Thank you. May I just have one other very quick question for you? I was interested in your focus group that language barriers didn't come out at all as a barrier. I thought that was interesting.
Well, those are sort of standard health system navigation issues, definitely, and the lack of resources in their languages is of course, an issue. Yes, thank you.
Yeah, language barrier came up in 2-3 different contexts. Like one is language barrier between individual patient and healthcare provider, and lack of communication around that, and then of course about presence of information in culturally and linguistically appropriate fashion. And that's where, for example, terms that is used for hepatitis C in India or Pakistan among a lot of population is not hepatitis C, it's something for jaundice, and that's very different when people talk about in their local language. So some of these issues need to be sorted out, and that's why we are developing some of these resources and testing these resources with these populations to make sure that they are able to understand what we are trying to convey, because in our English resources we may be using some different languages compared to what they are using in their own language.
Yeah, and interestingly enough, people are asking us to combine English and Punjabi in the same resource so that they can compare and contrast and make sure they understand if they are able to read both languages.
And that is also important from physicians' perspective, because like some of these resources are also useful for physicians for advocacy and for supporting their patients. And then if physician cannot read these languages, then it becomes kind of difficult. But when you have like an English interface, and then you have like in Punjabi or Urdu or some other language, then both can use the same resource and then communicate with each other as well.
Hi, I'm Cheryl Wrights from HepCVC. Hi, Lisa. I just have something I'd like you to comment on. This morning, Henry Koo said that the basic response of Public Health Agency of Canada to hepatitis C is prevention. But the immigrants are not generally at risk of either contracting or transmitting hepatitis C.
Yeah, I think that is very important comment, because immigrants, while they arrive here, they usually don't engage in activities that can lead to transmission. And most of them have acquired hepatitis C in their countries of origin, so they are more in need of screening and treatment. And frankly, prevention is also prevention of end-stage liver disease, and that will reduce overall burden of disease on our healthcare system. And from policy perspective, that is an important area for us to consider.
Mine is a comment more so about, well, you were speaking of the culture of fatalism, and I wondered if in your research you had discovered the level of ignorance or misinformation, I suppose is a more politically correct term. I've met and counseled individuals who would immediately say that HIV is a death sentence, HCV is a little malady, and have no idea that there's mortality involved in it at all. I wondered if you had actually, you would concur that the education need is really dire.
Yeah, exactly. The main issue is lack of knowledge about disease and what it could do to them, and whether there is a treatment that can cure them. And that is one of the major reasons behind this attitudes towards fatalism. Like, well, I've got it, I cannot do anything about it. And definitely there is a huge need for education around these things. Yeah, thank you.